These are come in the form of silicone sponges or tires. We can use radial buckles, mostly in the form of silicone sponges, and we can use also, or most commonly now, we use circumferential buckles in the form of silicone bands and silicone tires. These are just some pictures showing you the usual way of putting this scleral buckle. Scleral band here, usually it's tied down or anchored down to the sclera with the mattress horizontal sutures, and in the radial sponges usually are put radially to support a single break, and this will be the image inside the globe after you put multiple, let's say, radial sponges. Charles Capens is a famous ophthalmologist that probably started using the encircling bands back in the 1950s. In this historical perspective that he wrote back in 1991, he spoke about Jules Gonin, who in 1934 demonstrated that even if there was residual of subretinal fluid, if you closed a retinal break, at that time he did it with cautery, the retinal detachment will reattach if you close the break. So he's the first one to discover this finding. In 1937, Jess Temper used a gauze pad and sutured it to sclera as to first external scleral buckle. And in 1953, Custodis introduced a substance called polyvinyl as an external buckle, but this was abandoned because of the high rate of complications, particularly infection. Also in that era, Supramid and Merceline and nylon threads were used to as an encircling suture around the eye. So it's the same as the usual sponge or the encircling band, but it was sutures. But these had high erosion rates and led to numerous ocular complications. Scapens and his co-workers in 1957 introduced the scleral buckling procedure, the encircling band, and they used polyethylene tubing and to use it as an encircling element. But in the 1960s, the silicone rubber was in wide use, and Linkoff and McLean used silicone sponges in 1967. These are some various materials that have been used over the years as circular. Nowadays, we mostly rely on the solid silicone and silicone sponges for our scleral buckles. Properties that you need to have in a scleral buckle: it should be hydrophobic, should be soft, should be inert, not causing any allergies, and should be stable in a wide range of temperatures, and should be economic and have or retain their physical properties. There are many types of them. There are like the round bands, there's the oval ones, grooved sponges, and mostly we can use we use the round sponges or the oval or the grooved ones now. Advantage of scleral buckle, probably the best, best advantage of it is to have is an extraocular procedure. You don't need to enter the eye, and by doing that you reduce the risk of having intraocular infection. Usually there is no lens trauma in phakic patients, so patients can retain their native lens, and this will not affect their accommodation or cause cataracts. There is no usually iatrogenic breaks from your scleral buckle procedure, and there is no need to maintain postoperative positioning usually. It has low risk of glaucoma, surgery is cheap, and it has superior or similar outcomes to PPV in selected cases. For example, young myope who has an anterior and posterior hyaloid. But potential complications, I mean, every procedure has its benefits and its risks. So potential complications of scleral buckle is postoperative refractive changes, mostly in the form of spherical equivalent changes in myopia, diplopia, especially if you have a large tire or too much manipulation of the orbit around the eye, choroidal hemorrhage, anterior segment ischemia, buccal extrusion, infection, and persistent subretinal fluid are all complications that can complicate scleral buckle procedure. One of the steps that are usually done during scleral buckle procedure is to do an external fluid drainage. In the past, it was more popular to do scleral cut down, which is probably not as controlled as a needle drainage, and that can lead to subretinal hemorrhage, especially after cryopixy, retinal perforation, vitreoretinal incarceration, hypotony, and choroidal detachment postoperatively. So now most people who drain during scleral buckle procedure usually use a needle drainage with a 25 gauge needle and do it in a controlled fashion so to avoid these complications. But improvement in instrumentation for vitrectomy surgery over the years, with shorter operating time, decreased need for suturing, have all contributed to increased preference of surgeons for vitrectomy over scleral buckle for repair of retinal detachment. But we should always select the procedure that meets the need of the individual patient and would be based on the strength of clinical evidence. A number of prospective studies have evaluated the ideal surgical management of retinal detachment or Rhegmatogenous retinal detachment repair, but results have been conflicting. Retrospective non-randomized studies, which are the most of the studies that are in the literature, are flawed because they have selection bias when they do when they select the two surgical techniques. Some surgeons are more experienced with one intervention than the other, and this will lead to the selection and outcome bias. But regardless of a specific surgical procedure, success rate of all retinal detachments or Rhegmatogenous retinal detachments in the low and medium complexity cases have ranged from 68% to 99%. But there is also a team that, or a group of surgeons that would say, why not then combine the best of two worlds, do PPV and scleral buckle? And they kind of expect that because of this, this will have higher anatomical success because the scleral buckle will provide support to the vitreous base and also provide, and PPV will provide direct removing of vitreous traction on retinal breaks, and then you will have the best outcome. But we know from from the literature that this might not be the case. So what is the best treatment option for Rhegmatogenous retinal detachment? I think one way of looking into it is there's no one best technique for all cases. One should select the best procedure based on individual patient cases and what you have available. So an easy way to stratify patients who have Rhegmatogenous retinal detachment is to divide them into either simple cases or simple retinal detachment versus complex, or phakic patient versus pseudophakic aphakic retinal detachment. This will help us selecting the best surgical treatment. So either we do scleral buckle, pars plana vitrectomy, or we can do a combined procedure. This is a study that was published in 2007, scleral buckling versus primary vitrectomy and Rhegmatogenous retinal detachment repair. This was one of the very few prospective randomized studies in retinal detachment repair. In this study, which was a multicentral study, they separated patients into phakic and aphakic groups, and they were then randomized, and either patient had vitrectomy with an addition of scleral buckle if the surgeon decided, versus just scleral buckle alone. Their outcomes the main outcome was change in best corrected visual acuity, and the secondary outcome was primary and final anatomical success, and the incidence of vitreoretinopathy and cataract progression, and number of reoperations. These cases were medium complexity retinal detachments, so the cases that had the medium complexity retinal detachment were cases that had primary retinal detachment with large break, which is a break more than 1 or 2 clock hours, cases that had multiple breaks, cases with superior bullous retinal detachment, cases with central extension of retinal breaks, cases with marked vitreous traction on a break, or patients who had unseen or unseen hole preoperative were recruited for the aphakic pseudophakic trial only. So these cases, if they were seen, they were deemed medium complexity, and they excluded all cases with PVR grade B and C. So in this study, in the phakic group, the patients who had the scleral buckle, or in the scleral buckle arm, had better final visual acuity outcomes than the pseudophakic, than the pars plana vitrectomy group, and but the retinal redetachment rates the anatomical success, and the postoperative PVR were similar between the two groups. Of course, in the group that had the PPV, because these are phakic patients, most of the patients had cataract that required surgery at the end of the study. In the pseudophakic group, the visual acuity changes were a little bit better in the pars plana vitrectomy group, and the primary anatomical success was higher in the PPV group. So in their conclusion, their study showed that there's a benefit of sclerobuccal in phakic eyes with respect to best-corrected visual acuity improvements. And based on the anatomical outcomes in the pseudophakic trial, they recommended pars plana vitrectomy in those cases. In another study, which is a large study done by the European Vitreo-Retinal Society Retinal Detachment Study Group, they kind of divided the types of retinal detachment into uncomplicated retinal detachment and complex retinal detachment. So this first study was based on the uncomplicated detachments, and it was a non-randomized, multi-center retrospective study, and involved a large number of surgeons in different countries with 4,179 patients with uncomplicated retinal detachments. So these detachments were having either grade 0 or grade A PVR and without choroidal detachment, and there was no significant hypotony or posterior large or giant retinal tears. The main outcome measures were final failure of the retinal detachment repair, so level 1 failure. So this is like failure of the failure of the retinal attachment at the end of the study, or remaining silicone oil at the study conclusion, which is level 2 failure. If the patient needed additional procedure to repair detachment, this was called level 3 failure. And based on the variables they collected in these this report and the second report, they found that the variables that were linked to level 1 failure or failure at the end of the trial were mostly advanced PVR, detachment in more than 1 or 4 quadrants, and choroidal detachment and hypotony. The size of the retinal break was determined to be a major independent explanatory variable in the failure rate, and lens status and total numbers of tears were not linked to failure rate. Failure rates of segmental and encircling sclerobuccal were not statistically significant. So people who elected to do just segmental buccal versus 360 encircling buccal, there was no significant, statistically significant difference between the two groups. And again, these are just grade 0 or grade A PVR. The failure rates of vitrectomy with or without the buccal versus sclerobuccal alone in phakic and pseudophakic patients. So we can see that in the vitrectomy and with or without sclerobuccal, there was a little bit higher level 1 failure, and there was a higher level 2 failure, because this means that, of course, if someone did vitrectomy, there's a chance that they would put silicone oil as opposed to someone who had just had a sclerobuccal procedure. But level 3 failure was more in the sclerobuccal group, so there was a tend to having more than one surgery if you had just sclerobuccal. In the pseudophakic patients, it appears that level 3 failure or having to have another procedure was much higher in the sclerobuccal group. So both phakic, pseudophakic eyes, level 3 failure rates were significantly higher when sclerobuccal alone was used. As we said, level 3 failure was recurrent RD or membranes needed to be peeled for recurrent detachment. Failure rates with or without supplemental buccal versus sclerobuccal alone were a little bit higher in the combined group, and failure rates of vitrectomy alone versus sclerobuccal alone, so with no additional sclerobuccal, a little bit higher rate of silicone oil at the end of the study in the vitrectomy alone group. So regardless of lens status, eyes undergoing vitrectomy had higher chance of higher single surgery reattachment rate than those treated with sclerobuccal alone. Combining all uncomplicated retinal detachment, there was a higher rate of remaining silicone oil after vitrectomy. And considering visual acuity data was not taken in this or not available in this study, it's difficult to know if either a successful primary repair or successful final repair is most important for functional outcomes. In their conclusion, they concluded that treatment of uncomplicated phakic retinal detachment repair using scleral buckle may be a good option. In pseudophakic eyes, there is no clear winner. Surgeons should consider a higher risk of level 3 failure and having to have a second procedure with the scleral buckle group versus having a level 2 failure with having silicone oil in the eye with vitrectomy. And in combined procedures, there was no improvement in anatomical success, and there was more complication rate of retinal membrane macular edema and glaucoma. But how about complex retinal detachment? So the same group that done another report on complex retinal detachment, and their categories of complex retinal detachment were grade B PVR, grade C PVR, and choroidal detachment, significant hypotony, large or giant retinal tears, and macular holes. So choroidal detachment and hypotony were associated with higher failure rates in all the categories, especially in the PVR grade C group. Failure rates with grade B versus grade C PVR. Of course, the more advanced PVR, you'll have higher failure rates of type 1, level 1 failure, or a failure at the end of the or retinal not being attached at the end of the study was higher in the grade C group. Also, more chance to have silicone oil in the eye at the end of and more chance to have second procedure. The size of the retinal break was determined to be major independent factor in the failure rate. So as you get large break is more than 1 clock hour. So if patient had a large tear, they had a higher chance of having level 1 failure at the end of the study. How about comparing the vitrectomy with or without scleral buckle with scleral buckle alone in grade B PVR? So in grade B PVR, the patients who had the combined procedure or one procedure, vitrectomy alone, had less level 1 failure rate. But when you get the grade C PVR, there was higher failure or less failure rate in the scleral buckle group, but this was not statistically significant. Choroidal detachment or significant hypotony was much higher in the scleral buckle alone group to have than the vitrectomy plus minus scleral buckle group. And if patient had a giant retinal tear or large tear, it was better to be in the vitrectomy group. And this is to divide more vitrectomy alone versus vitrectomy scleral buckle. They found that vitrectomy alone had a higher chance of success. Combined procedure, vitrectomy with scleral buckle and relaxing retinectomy, the surgeon chose to add scleral buckle or relaxing retinectomy for those detachments. If he determined that this has introduced bias into the study because it's probably they will select these procedures for patients who are more likely to fail if they did not do this, and this probably will affect their outcomes. So in their conclusion, retinal detachment to choroidal detachment or hypotony, a large break or giant tear is present. Vitrectomy is probably the procedure of choice. If vitrectomy is to be performed, data suggests that supplemental buckle may not be helpful. But as we said, this might be a bias in the study because the surgeons chose to put the supplemental buckle in cases that they found or deemed to be highly, the failure rate will be higher if they didn't do this procedure, and by this they have introduced this bias into the study. Retinal detachment with PVR tamponade with either gas or silicone oil can be considered. So in a meta-analysis of primary vitrectomy versus scleral buckle for treatment of rhegnatogenous retinal detachment, they only found these studies that were deemed to be randomized controlled trials, and they found in the phakic group the patient or the outcome favors the scleral buckle group, and in the pseudophakic group the outcome favors the group that was in the Parspana vitrectomy group. Another recent meta-analysis of supplemental scleral buckle and in vitrectomy for repair of rhegmatogenous retinal detachment showed that when they did this study, of course, they excluded traumatic or juvenile retinal detachment and detachment associated with macular hole retinoschisis. So there was no complex retinal detachments. And they have done meta-analysis on the baseline characteristics. So if patient had inferior breaks, macula off RD, PVR, or pseudophakia, that they would account for this in their study. When they did the review of literature, they only found 10 studies that fit their criteria for the meta-analysis. And only one of the studies was a randomized control trial that they included. So they concluded that the quality of randomized control trials was considered low and high risk of bias because exact procedures for randomization, allocation, concealment, and blinding was not described. In all these trials, 360-degree encircling band was used, and when the surgeon decided to do a combined procedure. And because all included studies for meta-analysis were not, or most of them were non-RCT, it was important to address possible selection bias by evaluating the difference in baseline characteristics between the two groups. So macula off RD and inferior breaks were more common in those treated with the combined procedure. Advanced PVR was similar between the two groups. So this is the primary reattachment rate, and they found that this, based on these studies, it favors the combined procedures, so having PPV plus scleral buckle. The primary attachment rate was 92% in the PPV plus scleral buckle group, as opposed to 87% in the PPV alone group. And the advantages of the additional scleral buckle were not significant for primary attachment in pseudophakic eyes, with odds ratio of 1.28. The meta-analysis indicated that PPV plus scleral buckle did not result in a significant increase in postoperative cystoid macular edema, higher IOP, or PVR compared to PPV alone. So this meta-analysis supports to have combined procedure versus just PPV alone. There is a minimal, but there is an issue of unavailable high-quality RCT data, selection bias, and publication bias in favor of PPV. So if you go in the literature, mostly if surgeons have good outcomes with PPV, they will try to publish this, and as opposed to having data published on the combined procedure. In this study, done for patients with high risk of PVR, pars plana vitrectomy versus, with scleral buckle versus pars plana alone for patients with RD with high risk of PVR, this study was done at the Wills Eye Hospital and included reviewing 678 patients with RD, and they only selected 65 patients that had high risk of PVR. So the criteria for high risk of PVR were retinal detachment in more than 2 quadrants, retinal tear of the more than 1 clock hour, preoperative grade B or C PVR, and vitreous hemorrhage. In these patients, 36 patients had pars plana vitrectomy plus scleral buckle, and 29 patients had just PPV alone. And the single surgical anatomical success rate was 63% only. The patients who had the combined procedure had 75% success rate, and patients who had just PPV alone had only 48% success rate. So the combined procedure has significantly higher surgical anatomical success with the odds ratio of 3.24 as opposed to PPV. But when they did further analysis, they found that patients who were aged 65 years and younger, PPV or combined procedure had significantly higher success rates of 84% versus only 46% for PPV, and they found that patients who were older than 65 years old, there was no difference in anatomical outcome, and they attributed this to probably having more vitreous syneresis and more liquefied vitreous as a patient would age, and this would decrease the need for having support for the peripheral retina with a scleral buckle. The lens status and tamponading agent were not found to have significant effect on surgical outcomes, and overall 23% of patients developed postoperative PVR with no difference between the surgical approaches, and they think that this high rate of PVR postoperatively solidifies their selection criteria for high-risk patients. So this is a very high postoperative PVR rate, and this they think that this is because they have only selected these high-risk patients. So what is the new trend for scleral buckle? I know that from some of the retina group here in KKESH now they are doing scleral buckle with the use of the endoillumination and chandelier viewing system. And in 2016, Narayanian had pointed out that placing scleral buckle using endoillumination enabled the trainee or trainer to exactly see what the trainee or the fellow was doing, and this was having an additional educational benefit in training retinal surgeons. So now in like the last 3 years, maybe 2015 and 2018, there are many studies coming out of using scleral buckle and chandelier illuminating systems for doing scleral buckle procedures. And they all cite that this will allow better visualization of the retinal breaks to avoid missing any break, and it's kind of like improves or increases the or improves the training of fellows, and this might increase the or making the scleral buckle procedure come back in the 21st century. So chandelier insertion, but there's a caveat in this endoillumination system, is that when you go into the eye transsclerally with endoillumination or chandelier light, you are entering into the eye, and you are by this crossing off one of the most important benefits of scleral buckle, which is an external or extraocular procedure. Some of the papers that came out cited that there's a learning curve for this procedure, and that the chandelier insertion carries the risk of having cataracts from lens touch with the illumination, or creating new breaks from the vitreous traction during manipulation. There is also a recent report of endophthalmitis after chandelier-assisted scleral buckle surgery, but their reported overall success rate are similar to conventional scleral buckle, which is between 77 to 93%. So in summary, I think there's no good procedure for all retinal detachments. One should select the procedure based on the patient or the unique patient needs. These are probably the best indication for having a scleral buckle procedure done, either alone or in combination with PPV. So if patient has phakic, a patient is phakic with a young patient with no posterior vitreous detachment, this is the ideal candidate probably for a scleral buckle procedure. Patient who have peripheral retinal holes, localized RD, inferior RD, or multiple peripheral pathology and tears, or have retinal dialysis and no PVR are the best candidates for scleral buckle procedure. If a patient has complex retinal detachment, then probably combining with PPV is the option to take. But there are some certain RDs that can probably go for with just simple PPV without scleral buckle, which are detachments and simple detachments in pseudophakic patients, or detachments in the eye that have hypotony and choroidal detachment, patients who have RD with prolonged macular detachment so that you can drain the subretinal fluid quickly, patients who have PVR RD or RD secondary to macular holes, or RD with vitreous hemorrhage. It's important to consider individual patient factors, surgeon preference, and availability of equipment when you consider the best procedure you want to take. In the current era of vitrectomy, for most retinal detachments, there should be still a place for buckling surgery, and reinventing it by these new techniques of endoillumination and better training will do this. Revival of interest in scleral buckling approach might encourage surgeons to spend a little more time examining the retina preoperatively, and this alone might have a positive effect on the surgical outcomes. Thank you very much.
Thank you very much, Dr. Abdullah Al-Musa, for a very informative, fruitful lecture. Before I open the floor for discussion, just want to have a few comments. So we understand from this grand round that buckles are here to stay. And those who say, I don't like a buckle, well, retina does not like you, and don't go into this field, please. Regarding the The first study you mentioned about the randomized clinical trial about comparing, which was comparing PPV to primary scleral buckle, and you showed that although there was a higher rate of cataract in the PPV group, they still had a better visual acuity at the end compared to the scleral buckle group. Well, this could be because in vitrectomy, you aim to flatten the retina, the macula. You empty the subretinal space from all the fluid. Unlike in scleral buckle, even if you do drainage, external drainage, there is definitely still some fluid. And there are a few studies now looking at the effect of delaying the treatment, the RD repair beyond 3 days, and say that for within the first 3 days, actually, for each day you're losing a line. So this means that if you treat it with a buckle, you're actually maybe waiting and then waiting for the subretinal fluid to resolve. This is maybe an extra 1 or 2 days until you have the macula is totally free of subretinal fluid, and so you're losing time with the buckle. But this is one way to look at it. Regarding the chandelier, well, I've tried it myself once or twice. The problem with the cataract formation is usually with those that are very liable and free moving, while those who are self-retaining with a port that you enter it through and they stay there with no further manipulation from your side to maintain them in place, may be a better option. So those who from DORC are not good. The twin chandelier light are not a good option. Questions? Sulaiman, Dr. Sulaiman.
Thank you, Dr. Abdullah, for the excellent lecture. I have a few comments and one comment on your comments, Dr. Marwan. First, you mentioned in your comment on the chandelier-assisted buckles that by doing this you violate or you negate the benefit of doing an extraocular procedure with the buckle alone. Most of the time when we do scleral buckling, we do paracentesis. So I don't think the value of not entering the vitreous cavity with the light being a risk of I agree with the risk that it could touch the lens and it could cause more traction, more breaks, but having the light in the vitreous cavity is not I don't think it is the thing that we should because there was a case that was reported as endophthalmitis.
Yes.
There are cases of endophthalmitis that were reported after scleral buckling without chandeliers.
Yes.
This is one point. Regarding the point of delayed submacular fluid absorption after scleral buckling, there is a paper that looked into this because the fluid could stay for a very long time. And they looked at the final visual outcome. It was not affected. The fluid remained in many patients more than 6 months.
What do you mean by final visual outcome?
The final vision in that paper, they compared the group that resolved early and the group that did not resolve with the persistent fluid, and they looked at the OCT, and the final outcome in terms of vision was not affected.
How early? They don't resolve on the spot. I'm saying that when you repair them, I'm talking about very early RDs, less than 3 days.
Yeah, I understand your point in terms of macula off detachments, but once you seal off the break with the buckle, there is no current of fluid. There is a fluid that is
remnant.
Remnant fluid. There is no current of fluid. This fluid may take a very long time to absorb.
True.
And at least in that paper that looked at, it is a Korean paper in AJO, that looked at the final outcome, but they found that it did not affect the final outcome in terms of vision.
But they are comparing buckle with buckle. I'm comparing buckle with vit.
Yes, buckle with buckle, but buckle with with patients that the fluid resolved early, and buckle with fluid that take months to resolve. So I know it is we have patients with CSR that have fluid for months and months, and then they resolve and they have good vision. This is similar to the same concept because you don't have a current of fluid that is running.
I agree with Dr. Suleiman. I mean, we have, from my humble experience, I have many patients that had residual subretinal fluid after buckling procedure, or even sometimes after vitrectomy. There is like this thin layer of fluid that's always there in the macula for like at least 6 months. I found a patient that stayed for a year. But it appears that after the fluid resolved, their vision has improved. Yani, maybe not to the extent that you would expect, but it has improved a lot, even after like long time duration. So it is like kind of like a CSR type. One of my patients, actually, she had CSR, and that fluid is probably just because of the weak RPE pump. For the other comment about the chandelier or the light endoillumination and risk of endophthalmitis, like based on the studies that are done on the post-cataract surgery endophthalmitis, patient who just had cataract surgery, if you culture them immediately after cataract surgery, you'll find that they have some organism in the AC. But because of the aqueous fluid regenerates quickly, most of this is washed out and cleaned up, going to trabecular meshwork and going outside the eye. But the vitreous does not regenerate. So if you go into the vitreous and you inoculate the vitreous and then you close the wound, then you have the chance of having this infection, I think, more. But still, the numbers are low in these studies, so we don't know. Nobody has now a large study comparing this procedure to a standard buccal procedure.
Dr. Hassan?
Yeah, thank you, Dr. Abdullah, for this very nice and informative talks about the modalities that we are using in daily basis for dealing with them. I have been trained maybe before you a couple of years, and I started my practice when the scleral buckle was the main procedure to be done. And believe me, the tires that you showed there, I use it in a couple of patients, reaching posterior to the equator and fishing to suture the tire there, putting the encircling band. And for us, it was very beautiful to go with difficulty ended by the day to sleep 2 days for your next year. And applying a lot of cryo with his eyes. And seeing this patient having flat posterior part of the retina is good for us, and to keep patient visions. Looking for what we did in the past and comparing what we have in our hands today, dealing with the retinal detachment, showing that the Barca-Plana vitrectomy is getting more and more effective when you compare it with our 20 gauge, with this meticulous instruments to go in and to fix the retina, and how much of break that we are creating during this. So I think so by the time being still, the scleral buckle is valid, but it is not as we do in the past, putting that big,
Yes.
Radial buckle and disfiguring the sclera, and even though putting the tires. You can use it with a small sponge for that break, located in area that accessible for you to go on in a patient with good sclera, not very thin. For that patient having peripheral, breaks at the ora serrata, that you can easily access it with the encircling band. But if you need to do vitrectomy, do it for these cases. So I'm really, the statement that you said by the end, there is no, let us to say, relative and absolute. You are the one who should decide which one I'd go for. For the patient who's having chronic RD and you are a little bit scary to go in the vitreous, this is the time where you have to deserve to apply your scleral buckle, because that's important to fix this retina. How much of subretinal fluid going to be absorbed in the first, second day post-surgery? This is depending on the chronicity, most likely. Acute RD, I'm sure that within a couple of hours, I say, after crossing your break, even the space between the retina and the choroid, 1 millimeter or less, it will close and immediately go. Anything larger than this and your residual subretinal fluid, mostly your break will not buckle, and then you might need to do another procedure. So don't ignore scleral buckle. Keep it in your mind. Put it your, this is the choices. I see nowadays we have more ability to deal with RD. But in our country, think about people with having abnormal vitreous, where you can get in and then you cannot deal with it. And the buckle, good choice for them.
Yes, this is something that I realized when I started to practice here.
So it's not an easy that you go your vitrectomy and finish.
Yes.
5 days later on after your gas, you find the BVR is working there.
Yes.
And then no buckle, no vitrectomy could help.
Dr. Yahya?
So there is also, thank you Abdullah for a very nice lecture. There is one point, if you go inside the eye that had buckle before, it's much easier to deal with retinal detachment compared to go back in the eye which had vitrectomy without buckle. So buckle is very important. We should not ignore buckle, especially for the institute like KKESH or the university or the trainee. So they should be trained on the scleral buckle. I do agree with the criteria that you put for the. This is the question that I ask myself and my fellow when we see these cases. The first question: what's the age of the patient? The second question: is he phakic or aphakic or pseudophakic? Third question: does he have BVD or no? So this is a very important question to answer to decide which procedure you go with the buckle with vitrectomy. You like to go with the buckle for young patient who didn't have BVD with the small breaks peripheral, or even if you have like traumatic dialysis that you can put sponge there and close the dialysis and that's it, instead of going in and create this child or this patient for cataract, then pseudophakia, then amblyopia, then glaucoma, a lot of complication of BBV. So BBV is very easy to go nowadays with a small gauge, but again, think about the complication rate.
Yes, okay. Very rewarding.
Dr. Saad?
Thank you, Dr. Abdullah, for this nice review. What I'm doing nowadays, maybe more seniors here in the auditorium than me, when I see an RD in the ER, I ask myself, is it can be done by buckle or pneumatic retinopexy? This is my first question I ask myself. If it's not, then I go for vitrectomy either alone or combined. I don't remember, I regret from doing buckle alone. I start review the cases that I'm done. I don't claim that I did a huge number, but I never regret that I did buckle. Even cases that failed to buckle, which was few, and you always recognize them on table. You know this buckle will not work because you see the retina is not flattened or the view is hazy, you could not assess the break well. Even those cases that buckle done alone and I found next day it's not successful, when I go for vitrectomy it's much easier, as Dr. Yahya mentioned, and also the tamponade selection is much easier for me. Inferior breaks with buckle, I will be more comfortable to use gas compared to silicone oil. So for the new generations and the retina fellows, always ask yourself when you see a case of RD, is it good for buckle alone or pneumatic retinopexy before going for vitrectomy? Because some cases, if you go in and there is a remnant hyaloid that was very thin, you cannot see, and they come with BVR, as Dr. Hassan mentioned and others, it's very difficult to fix the retina. So remember always to think about pneumatic retinopexy and buckle as the first line treatment for going to vitrectomy for cases of Rhegmatogenous retinal detachment.
So as Dr. Hassan mentioned, think of how to fix first with scleral buckle. If not, then go again for vitrectomy.
As for primary, I did a lot of encircling band with primary RDs. And in my mind, that the success rate with this procedure is really a bit superior to the doing alone just vitrectomy. This is my experience with myself. I cannot say that I have some published combined encircling band with vitrectomy.
I think it has to do with the selection bias, because when you see a simple case, you think PPV alone will be enough. And it is a simple case, so a simple outcome. But if it's a complex case and just do PPV, then you'll have bad outcome. If you do a complex case and you think you'll do both, even with the both procedure, combined procedure, the risk of having complication is much higher when you have early PVR and complex detachment. So I think that always pushes back the combined procedure to having lower outcome because it is always selected in the worst case.
Actually, I'm a man that I don't like to have any. So I'm doing buckle, a circling band, 360-degree lasers, and vitrectomy. But actually, this is too much sometimes, you know. But I found that myself, the failure rate is really acceptable, not that obvious as we.
I know if I talk to Professor Ahmed about combined procedure versus doing single procedure, he'll be angry at me and not talk to me, for a day because you just select one procedure. You have to do both.
Yeah, thank you very much. And I fully agree with all your statements, everybody's statements here. And the thing is, the real talent in doing vitreoretinal surgery is selecting the minimal job that will get the job done, the minimal act that will get the job done. So the technique is very important, but much more important than the technique is the judgment. And the judgment, you get it if you have good training, and you get it when you have practiced indirect ophthalmoscopy, and when you have practiced learning, how to indent and very quickly localize pathology and deal with it in the quickest way possible before the pupil starts to go down, becomes smaller, before the cornea becomes, visibly edematous, and before you run in trouble. So practice is the way to go with clinical examinations during the clinic with scleral depression. Then a good mentor that teaches you the good techniques of suturing and the good techniques of localization. And once you've mastered that and you've seen that, then automatically you're comfortable now with doing a buckle, and then I think that you will invariably choose what gets you the least in trouble, and that is a scleral buckle. A scleral buckle is ideal for simple cases, for cases where for instance, you cannot posture, or superior breaks, or even inferior breaks. As long as you don't have too many breaks at two different levels, as long as you don't have, giant breaks more than 90 degrees, as long as you don't have PVR, that is significant. Then a scleral buckle, it should work. It should work, and your judgment during the surgery will tell you whether you need to inject a little bit of gas to push the retina a little bit, closer to the buckle or not, whether you need to do a paracentesis or not. In most cases, you'll be able to do it without a paracentesis. So even having a film of fluid, I think may not be a very big deal. If you have a chronic fluid, your judgment will let you know that you need to probably drain, because if you have, you'll probably wait many, many months for the fluid to go away. But if you have recent fluid, then maybe you don't need to drain. And if you're 100% sure in your heart that the brakes were closed, then you don't need to worry too much about drainage. Actually, in AMD, and in cases, where people are using anti-VEGF, it's been shown that actually having a thin film of fluid remaining may be even protective for the retina rather than, completely drying the retina immediately. So do the minimum gesture that gets the job done, because once you've invaded the vitreous, I agree with Dr. Dibi and Dr. Dahmash and everybody else, then you are in a cascade of trouble. And if you don't know how to manage it, then better not do it.
Last comment.
Yeah, one comment here. So BVR doesn't mean that you have to go for vitrectomy. So if you have BVRs, again, you can manage with the buckle. So I look at if you don't have posterior, posterior BVR, I usually go for vitrectomy. Sorry, for the buckle. Even if you have like a peripheral circumferential subretinal bands, still you can manage with the buckle. So BVR, it didn't equal vitrectomy. So again, BVR can be managed with the buckle alone.
Okay.
Please don't take RD lightly.